Welcome again to another Face Coach presentation. This one's on a rethink that we've had, Mike Clegg and myself, about hyaluronidase injection after intravascular injection, which has either resulted in the potential for skin necrosis or blindness, and looking at other options for treatment of retinal artery embolism caused by intra-arterial injection of hyaluronic acid. This is the problem that you can see here with the red arrows go, that hyaluronic acid clogs all vessels in its distribution from an intra-arterial injection point. In other words, downstream, if you're thinking of it like a tree, all the leaves and the terminal branches are clogged with hyaluronic acid, and therefore that makes themselves a little bit more difficult for any collateral to vasculature to actually make an impact on refeeding those threshold areas with blood supply, because all the terminal arterioles and capillaries are clogged with the substance. Just for a little bit of intravascular reassurance though, because it appears that despite the fact that in 52 respondents over 16 countries, all of whom were experienced, but 71% had at least 11 years of injection experience, and all of these respondents were actually trainers for companies in injections of hyaluronic acids, that 62% reported one or more intravascular injection episodes clinically. The most frequent initial signs were minor libido in 63% of cases, pallor, and symptoms of pain in 37%. Note the low percentage of pain, we'll get back to that in a little while. Mildness or absence of pain was a feature in 47% of patients. So 40%, 70% of events did not have pain as a presenting sign. So that is a crucial issue that you need to look at. Pain is not necessarily a sign of these events. Hyaluronidase between 5 and 500 units and over 500 units was used immediately on diagnosis to treat 86% of cases. Now, 5 units is pretty useless, so don't really go to that, but you can really look at the 500 units and above as your new threshold for treatment of intravascular hyaluronic acid injections. The most commonly affected areas were the nasolabial fold and nose, each 39%. So the relatively benign area, inverted commas, of the nasolabial fold, where everybody started to be taught how to inject in these areas, is a very critical and problematic zone and equals the nose in its likelihood of producing issues. Of all cases, interestingly enough, and this is the reassurance part, only 7% suffered moderate scarring requiring surface treatments. Uneventful healing was the usual outcome, with 86% of cases resolving within 14 days. Now remember, we only asked in this particular survey the worst case of the person of the respondents, only the single worst case. So all the minor, less severe cases must have had a better natural outcome than these cases. So resolution appears to be the most likely thing to happen. If you look at hyaluronidase injections in this study, in this paper, the thing that I want to highlight is that this rabbit ear had hyaluronidase injected not intravascularly when I'll go back a step. Hyaluronic acid was injected intra-arterially into this rabbit ear, and then hyaluronidase was injected subcutaneously or not injected at all. And this was the appearance 7 days later. Now this was injected 4 hours after hyaluronic acid injection, so it is critical to be pretty swift with your hyaluronidase if you can. But one shouldn't necessarily extrapolate from rabbits to humans as to how fast you need to get in there. I think hyaluronidase at any stage after inadvertent intra-arterial injection is important. But obviously subcutaneous injection route, and we know this, can get across blood vessel walls and can actually stop the effect of an intra-arterial hyaluronic acid injection. So you don't have to be intra-arterial to improve the outcome of intra-arterial hyaluronic acid injection. So 14 days later, you can see the necrosis in the one that was not injected with hyaluronidase, and a normal looking ear, the one that was injected. And again, this was a subcutaneous route, periarterial, not intra-arterial. Now, this is a paper that we, or a letter to the editor that we wrote up, Mike Clegg and myself, on the Rethink, and please have a look at this. It's Dermatologic Surgery, April 2016, and read the commentaries that followed as well. But basically what we were saying is that the facial blood supply is very rich, but embolism blocks the end vessels with consequent necrosis across a wide capillary bed, and all the anastomoses don't matter if the end vessels are clogged up. So if all these are clogged up, all the other vessels feeding into this from other circulation will not help the blood supply of this clogged up capillary bed. Things to discuss with intravascular injection: where you can get access to downstream circulation, such as the usual case of intravascular obstruction. So if you've got a premesenteric notch, you can kind of get in possibly into the facial artery or perifacial artery in the downstream route. If you've got an embolus down here onto the lip, into the inferior lip, the superior lip, or up into the nose and perialar area, you've got that as an access point. You have the access points above that of the upper nasolabial fold, where you know that just lateral to the nasolabial fold in the deep subcutaneous tissue, the angular artery will be a possible target for getting into if you want to, or get around that major vessel. Sometimes you can't get access to upstream circulation, for example, in cases of blindness, because in cases of blindness, the vessel coming in is coming from the internal carotid artery that we really can't get access to that easily, and the ophthalmic artery coming up here is providing the initial vasculature to the eye, and you're just not going to be able to help that by injections, for example, in or around the supratrochlear or supraorbital artery or dorsal nasal artery, where you can get access to the circulation. We'll describe that. We'll discuss that in a minute anyway. So the internal carotid arteries and the ophthalmic arteries you can't get to that easily at all, to allow the downstream route of the vasculature. And I was injecting here, ideally would be here, and you would have a downstream route that would allow you access into the retinal artery and the ciliary arteries. Problem with fillers and embolism is as follows. You inject down here, might be a small vessel you get into, and you might be putting a bolus in thinking you're safe and everything's rosy in the garden, and you keep on injecting and it keeps on flooding against the arterial blood pressure all the way down until you actually release the syringe pressure, and then you let go and everything goes back the other way. So everything reverses back into the tributaries and all these things get clogged up. So once that happens, that's where the problem seems to be occurring. So hyaluronic acid clogs up these end vessels. So a rethink on that. This is a problem. A rethink, since we do see hyaluronic acid crossing vascular walls, and we do have access points such as we discussed before, around the facial artery in particular and the angular artery in particular, where we think we know things are fairly fixed and fairly definitely there, then that's an easy access point. We should think about injecting very high dosages around these vessels in the order of maybe 1,000, 1,500 units, that sort of thing, in and around the major truncal vessels, so they can cross into the artery and be carried downstream by the normal arterial pressure into these areas where the hyaluronic acid has occluded the vasculature and may actually release the vasculature. So not only do we want to inject in this distribution here, we want to actually be thinking about where the origin for this distribution is seen, and that unclogging the vessels with any luck. So as we said before, lots of possible entrance points, possible areas. So the facial artery down here is an access point, access anterior to the masseter, and that little notch that we know is there.